I like to start with the very basics, meaning the understanding that different diseases that affect the different parts of the body are going to produce different signs and symptoms that are manifestations of an underlying disease process. Okay? And some of us don't know that there's a difference between a sign and a symptom, at least clinically or medically. A sign is an objective manifestation of a disease, and a symptom is subjective. Okay? When a health provider sees a constellation of signs and symptoms that are coming together that are indicative of an underlying disease process, we call that a clinical syndrome. Okay? Keep this in mind as we move along this discussion. And I'm going to start with a very simple example so everybody's on the same page here. Everybody's familiar with a lung infection, for example. You have the airspace that looks nice and healthy over here. In the picture below, you see it filled with purulent material, inflammatory cells, etc. This is basically what is happening at the level of the organ, right? When you have an infection of the lung. And this produces symptoms and signs of an infection of the lung. Symptoms include body aches, maybe low energy, shortness of breath, chills. I told you these are subjective symptoms, right? Meaning they're subjective to the health provider. I cannot quantify someone's body aches, right? In the same way that I can measure someone's fever, or I can put my stethoscope on someone's chest and feel or hear the wheezing. These are objective manifestations of a disease, and that's a sign. Okay? And we call this signs and symptoms a syndrome that we give it the term pneumonia, correct? And that's how we, as health providers, say, I have a patient that has pneumonia, and that means that I am talking about a specific disease process that is affecting a specific organ in the body, the lung, that is producing a specific clinical syndrome. We're all on the same page about this, right? It's important to keep this in mind because we bring this into the brain as well. But the difference between the lung and the brain is that unlike the lungs, the brain does many different things, right? The lung essentially does the same thing, it moves gases. And if you have a pneumonia that is affecting the top of your lung and a pneumonia that affects the bottom of your lung, the signs and symptoms are going to be the same. But if you have a disease of the brain that affects the front of your brain or the back of your brain, the signs and symptoms of that disease are going to be extremely different. So that's the challenge that we have as neurologists, or psychiatrists, or anybody interested in brain diseases, as we're learning, right? So different regions of the lungs do the same thing, but different regions of the brain do dramatically different things. And this is the concept of cerebral localization that really guides everything that we do. And I'm not going to go through this in great detail, but I just want us to recognize that the idea that different parts of the brain do different things is not merely an idea, obviously. It's something that stems from, it's a historical account of hundreds of years of observations of what happens to a brain when it's injured in certain parts, or when there's a disease process that affects certain parts of the brain, and what are the ensuing signs and symptoms that a person experiences. So I'm going to go through some of these facts just to put us on the same page. We can go back to the early 1800s. A German physician, Franz Gall, he had the first inkling of the idea of localization. But interestingly, well, he was obviously wrong. He thought that he could actually palpate bumps on the skull. Are you all familiar with phrenology? Anybody? Yeah. That you can palpate bumps on the skull and make predictions about a person's personality or behavior just by palpating the skull. Crazy idea, but he was kind of on the right track, it turned out later, right? Obviously, this didn't pan out, test of time. Later, 1848, this very famous case of Phineas Gage. He was a railroad construction worker in the United States. He had this metal beam go through the front of his brain. The reason why this case was so celebrated and studied is because he survived, but he had a dramatic change in his personality and his behavior resulting from this brain injury. So it really attuned the sciences into the frontal lobes as a hub of behavior and personality. Later, we come up with this guy in the late 1800s, Paul Broca, who was very obsessed, was very curious about people that had strokes of the brain that resulted only in changes in language. He thought, well, there must be something very specific around language. And he studied all these brains of people that had stroke and really pinpointed the areas of the brain that help all of us communicate, use our language. Very important for FTD as well, to keep this in mind. As time advanced, we had other interesting people that got really interested in looking at how do the regions of the brain that look different to each other are correlated with different functions. We have this guy, Caribbean Broadman, who actually blindly studied a ton of brains under the microscope, and he saw that indeed different regions of the brain had different cytoarchitectures, meaning the cells look different as he moved from the front all the way to the back. And he saw this repeated over several cases, right? And then he started to color the areas that look different, from each other and gave them numbers. And then went on to study how these brain regions correlate with specific functions. And even today, we use this map. For example, this area here that you're seeing in black dots, today we call it the motor strip, because this is where all the neurons that control movement on the opposite side of our bodies live, right? These regions here, area 17 and 18, are exclusively dedicated to vision. We don't see with our eyes, we see with the back of our brains. When I have a pathology that affects the part of the back of the brain, this person will not have weakness, will not have trouble with speech, they'll have trouble with vision, okay? And so forth. You can make a lot of conclusions around architecture and function. We have more modern maps here that we don't have to delve into, but this brings us to our current understanding of how the brain works in a very, very broad point of view, where it's a modular and a distributive model, where you have some nodes that are very specific to certain functions, like the motor strip, right? And other areas that are working together to bring us one of our human faculties, like perception, interpretation, and so forth, okay? And so as neurologists, we try to bring this to bear when we're evaluating patients, and we all carry this is a very simplified anatomic understanding of certain functions, human qualities that are mapped out to different parts of the brain. And again, we see the nodular nature of some functions, like vision. Elementary visual processing is really focused on the back of the brain. But you see other functions like language that are distributed. You have some language that is dependent on the parietal lobe, some that is depending on the frontal lobe, some that is even dependent on the temporal lobe, and so forth. Now, this is very simplified, but just so we can grasp the understanding that these are networks and regions of the brain that we depend on to be human, right? In all of our facets, speech, navigation, emotion processing, etc. I'm using the word dependent on because I don't know if that's where these things are born. Who knows? But the point is that if you injure these regions, you're going to experience changes in your humanness. Okay. Now, if we zoom into a brain, it's very fascinating because what we find is a very simple, well, not very simple, kind of simple structure relative to the complexity of function, right, of a human being. You have arteries, glial cells, neurons. Turns out there's other type of cells in the brain as well, as we're learning. But, the point is that, down there's not a lot of substrate. But interestingly, we use this substrate to think of different diseases of the brain that attack different substrates. So, for example, we have the cerebrovascular diseases, stroke, demyelinating diseases. There are multiple sclerosis that attacks the myelin sheath that covers neurons. Infectious diseases that don't respect any substrate. They get in the brain and they attack it all. Blood vessels, neurons, glial cells, whatever. And finally, we have the neurodegenerative diseases. This is where FTLD and Alzheimer's and all of these other diseases that you're learning about live. Alzheimer's being the most common neurodegenerative disease. But there's others, okay? So this is how I want us to think, if at least for this session, about these diseases. They live at the level of biology. Alzheimer's disease is one, the most common neurodegenerative disease. There's others. We're going to focus to the unfrontal temporal lobar degeneration, but there's Lewy body disease, there's Parkinson's disease, corticobasal degeneration, progressive supranuclear palsy, the prion diseases, and others. Each of these diseases has its own characteristics molecularly, okay? What they all have in common is that they lead to neurodegeneration. You can see that these are two brains that are about the same age. You see the brain on the right actually has FTLD, I'll tell you that. And you can tell because the front of this brain, if you compare it to the front of the healthy brain, you can all see it looks smaller in volume. It's reduced mass. That's because of the process of neurodegeneration. All of these diseases have atrophy in common, okay? But the difference is that the atrophy is going to affect different parts of the brain more than others in the early stages. And that is why we think you see such dramatic differences in the signs and symptoms. If you compare someone with typical Alzheimer's disease that is affecting more of the temporal lobes, you're going to have memory problems. But you have someone with Parkinson's disease, where the neurodegenerative process is affecting the motor centers of the brain, we're going to have memory problems early on. You're going to have motor problems. And that's kind of how we need to think about these diseases. And this is why we do MRIs. So this is a person with FTD, and you can see, you know, in light gray is the brain tissue. You can see the back. This is a sagittal cut, so it's a cut done right through the middle of the head. And you can see yourself, you know, the back of this brain looks pretty healthy. There's a lot of light gray, a lot of brain tissue, compared to the front of the brain. The light gray tissue has been substituted by fluid, and that's what you see in black. Fluid takes over the spaces where there's brain atrophy. You can look at it in a different view. This is an axial view. Again, you see more fluid here accumulating in the front of this brain in the medial frontal areas compared to a healthy brain. And this is the orbitofrontal cortex. You can see a bigger streak of fluid here compared to a normal brain where everything is more tightly packed. Over years of doing this research, what we've identified, not we here only, but across the globe, is that different syndromes will correlate with different, and now you know what syndrome means, different signs and symptoms will correlate with atrophy patterns of different parts of the brain. So in Alzheimer's disease, the atrophy is mostly in these blue areas, back of the brain, temporal lobes that are not shown here. In BVFTD, more the front of the brain, temporal areas. Semantic variant of PPA, it's more the temporal pole, so the very front of the temporal lobe, and so forth. That's a very key concept to also grasp for those of us that are not in the medical sciences or in the arts, the idea that specific diseases attack different parts of the brain and therefore produce different signs and symptoms.